So this patient in her 80s has pseudoexfoliation, doesn't dilate very well, obviously. So we're going to plan here is to put a toric lens in, but we may have to enlarge that pupil. So this is the left eye. I'm just going to stabilize it, although she seems quite steady, and do that little side port there. And then our 2.4 clear corneal incision. Little wiggle gets you in slowly in a shallowish chamber. Intraocular lidocaine. Now the order in which I'm going to do things here is a little different. I'm going to put some Provisc in first, and then I'm going to use a Bieler pupil dilator. So there's our Provisc. And the reason I'm going to do that is because after I dilate or expand the pupil, I want to use the trypan. And if I put Viscoat in, I might not be able to get such a good stain. Okay, so here we go with the Bieler. And then I'm just going to go to the side here and hook the iris there, and then come back to the subincisional region and then stretch it. Okay, so now I'll take the trypan and I'll go underneath the OVD and to the surface of the lens and put in the air bubble and then the trypan. And I just lift the iris up there a little so that the trypan gets out a little more into the periphery. Now the next step will be to inject the Viscoat, and that typically expands the pupil a little bit more. So let's see if that happens. So we got a bit more expansion now with the combination of the stretch and the Viscoat. Wet the cornea, please. Good. So now let's see what we have for zonular integrity. This is the Provisc again, opening the anterior capsule. Okay, so we'll stabilize globe position and do our capsulorhexis here. So far you'd probably say, yeah, there's some sign of zonular laxity in that supranasal area. A bit over here too, see the wrinkles in the capsule, but thus far I'd say we're okay without capsule retractors. So there goes our hydrodissection on one side, pushing the nucleus back down. Hydrodissection on the other side. So I know I've got a loose nucleus there. You can see I just rotated it slightly. And now we'll do 360 degrees of viscodissection. In the subincisional area, I'll viscodissect through the side port. Okay, we have epi in the bottle so that hopefully that pupil will stay its current size. Might get a little bigger, but I wouldn't bet on that. Make sure we've got good infusion flow. There we go. Okay, chopper goes in, right into the incision there. Now foot pedal position 1. So what I want to do here is get the nucleus divided right off the bat without stimulating the iris to contract. So there's one chop. Here's another. Zonul's holding up and looking pretty good here. So I'm going to go on. Usually I'll take the first segment out, but I'm going to go on and make my 4 cuts. It was bimanual nuclear rotation, so I don't stress the zonule as I do it. Okay. I think I've still got a nice chunk of nucleus here. And this chamber's a little shallow, so let me now have 5 segments. Let's go quadrant removal now.
Quadrant removal.
And so far that pupil's staying pretty much exactly where it was after we stretched it. Wet the cornea. Notice where I have that chopper kind of course, beneath the phaco tip, but also forward of it. Why do I do that? Because every so often in one of these eyes, that peripheral capsule will just come toward the tip. In these, if the zonule is deficient. You can use a low flow and reduce that, but if that also slows your procedure down and your pupil might come down. So that's why I have this tip of the chopper down and ahead of where the phaco tip is. So now we're ready for INA. So we'll proceed here to cortex removal, kind of tangential stripping here. There we begin to see some indication of zonular laxity, and as the cortex removed, you could see the little lens fragments back there. Infusion misdirection, not a surprise, kind of expect it. So you can see, those of you who were watching in 3D could see how far posterior I put the spatula. It's a good 3 millimeters posterior to the position of the INA tip. And here goes the kind of subincisional area. Again, the spatula holding the capsule back. Okay, so now we're ready to put in OVD. I'm going to polish that PC a little bit as I do it. And then the question is, do you need a CTR, capsular tension ring, or not? And in this patient, I'm going to say we don't. If the patient were, 70-ish, I'd put one in. But not necessary here, I don't believe. So we'll proceed to IOL insertion with our toric IOL. So now we've got a nice clear central posterior capsule. So that's the axis we want this toric IOL to wind up at. And I'll rotate it close to that axis before it fully opens. There we go, down in it goes, and rotate it over while the haptics still haven't unfolded. And then I'm going to let it unfold right around there. Now I've got to get OVD out from behind the toric IOL. That haptic still hasn't expanded, and you know what, I don't honestly care yet that it hasn't. So gently behind the IOL, and then OVD removal from back there. And now, before I take OVD out of the anterior chamber, there goes the haptic. And I'm rotating the toric into the axis here. And dilated enough to see the little dots. If you couldn't see them, what would you do? Well, you'd use a Kugel hook or the spatula, and you'd push the iris into the periphery, and or you'd tilt the eye in the direction necessary to see beneath the iris. But this pupil is just big enough I don't have to do any of that. Okay, so now we'll irrigate the OVD out of the anterior chamber. And especially out of the filtration angle. And postoperatively, what you'll see in these pupils is they'll be a bit bigger than they were pre-op, and the margins will look a little serrated, but not enough to even be a cosmetic issue, really. So that's our procedure, pseudoexfoliation in a patient with a mid-dilating pupil.